TopMedTalk. Welcome to TopMedTalk, live from the American Society of Enhanced Recovery and Evidence-Based Perioperative Medicine Annual Congress in Fort Lauderdale, Florida, USA. So here we are, 2018, back for another ASER conference. Last year we had our first live transmission from here. I'm Monty Mythen, Editor-in-Chief of TopMedTalk and Chairman of the Board for Evidence-Based Perioperative Medicine International. I'm joined this morning by Dr. Joff Lacey, anaesthetist and perioperative physician from London, and Professor Mike Grocott, anaesthetist and critical care physician from Southampton in the UK. He's on the board of Evidence-Based Perioperative Medicine and also on the advisory board for ASER. So, gentlemen, here we are a year on. Some reflections on last year and some comments on what we might be hearing today. Joff, why don't you kick us off?
Thank you, Monty. Yeah, well, it's great to be back at ASER. As you say, we were part of the first live transmission from TopMedTalk in Washington last year, which was a fabulous meeting, and probably some of the highlights being the work coming out of the Perioperative Quality Initiative, POQI. So a lot of chat last year about intraoperative, but perioperative included, analgesia, the opioid crisis, etc., and how we can manage that as perioperative physicians. And also many other elements of the bracket of papers that we discussed last year. And similarly, this year, I'm excited by some of the releases coming out of the POQI process, so particularly looking at blood pressure. So that should be an exciting meeting again.
Great stuff. So, Mike?
Yeah, looking forward to this. It's a delightful change being down by the sea instead of in Washington, D.C. I think some really interesting stuff around perioperative blood pressure, which was bubbling up last year, and then we had a POQI meeting last summer in London, and I think there's going to be a very interesting conversation around that here, and some interesting sessions on the whole leadership, ownership, partnership areas of the fundamental importance of team working in enhanced recovery.
So then one of the big jumps forward from last year in the blood pressure world, we all recognise the fact that there's an association between low blood pressure and outcomes. That's reinforced very solidly. But we've seen the first interventional trial, which we discussed in the ASA podcast. You just reflect on that for a second, Mike?
Yep, so very interesting, well-designed, randomised control trial appearing to show benefit from a group who had a more tightly controlled blood pressure approach, although not huge differences in terms of magnitude of pressure, and some very interesting results in terms of the underlying possible mechanisms, and that the pathophysiology, which I think we all thought was going to be about cardiac injury, actually the harm does not appear to be on the cardiac side, which is intriguing.
Now we'll come back to that in Journal Club, where we're going to discuss in great detail some of the papers that we've highlighted on Journal Club Express on the TopMedTalk website. But there seems to be this international discussion now that there's a lot of MINS, this troponin rise post-operatively in the United States of America, that we don't seem to be reporting with the same incidence in the United Kingdom and or Europe. Any ideas what's going on there?
Very unclear. Part of it is I think that in our routine clinical practice we're not looking for it as much and that we're not doing that kind of testing. But in the studies, if you compare between continents, there does seem to be a much less substantial signal in Europe, and I'm very unclear why that's so.
So luckily this morning we're joined by some guests, and first guest I'm going to introduce is Dr. Pat Shanahan, Director of Anesthesiology at Enterprises Glenview, Pat, there in Kentucky in the USA. Now, Pat, we've had many discussions over the years about enhanced surgical recovery, but in that context particularly how the multimodal analgesia embedded in enhanced recovery may contribute in some way to reducing this new syndrome, this new disease that we may partly contributed to, which is this persistent post-operative opioid use. Could you give some reflections on that, Pat?
Yeah, I think that that is one of the key things that this movement, and I'll call it a movement, that we have has contributed to the medical community, at least in the United States, is the concept that we don't need as much narcotics to take care of patients as has been in the past, and at least in the last 25 years, for patient care. The 2017 meeting that we had in Washington, I had the opportunity to speak with some representatives from Congress to talk about this on a regional level and how we could manage it, and discussions with HHS over the last year and a half. Some recognition by the White House that this is of interest to the nation. But really, because of the way the government moves, it's been rather slow to come up with any ability to put funding toward prevention of the narcotic expansion in the country. I mean, the focus is on managing those that are addicted and those that are causing problems because of the addiction. And what I think our perioperative situation can do is stop those who would enter into addiction. And for the future, I think that is the answer, because the youth of America, once they are exposed at an age 14 to 21 to narcotics for any length of time, are much more likely to be addicted afterwards. And this is an iatrogenic problem that I think we can solve by just addressing the multimodal pain management that ASER, ERAS, and EPROM is putting forward.
So we touched on this yesterday, but we had one of these perioperative quality initiatives, POCI, earlier in the year, where a group of us were brought together to focus on this new syndrome, this new disease, this persistent postoperative opioid use. And in that, I learned a lot about this new definition of the previously opioid-naive patient. And it appears from the results of all the evidence we presented that for major surgeries, perhaps as many as 1 in 10, conservatively 1 in 20, people are new addicts after major surgery. Now, to be fair, we don't have control group data for that. We don't have reference data to say what happens in the general population. But I was really shocked by that, and almost all that data is from the USA. Do you think that's accurate, those numbers?
I think that's an underestimate, frankly. I think there are papers out there saying that exposure to narcotics for 5 days, consistently for adults, children particularly, but for adults also, about 20% of people end up addicted after that.
And part of this seems to be the pharmacology, as we've craved these drugs, sorry, crave a bad word, maybe it's a good word to use here, that have the greatest pain-relieving effects with the fewest side effects. They're kind of like designer addictive, is the alternative view of that.
Yeah, I've had conversations with some of the individuals who started the synthetic narcotic situation for the United States developing these drugs. And several of those individuals, and I won't mention names, said, I would rather not be exposed to these drugs because they addict you as soon as you're aware you've had them.
Mike Grocott, do you think this is the same thing's going on in Europe, in the UK in particular?
I think it's going on, but at a much lower level. One of the things I find striking about the United States situation is the bystander harm as well. So if you send someone home with say a month, 30-day set of pain relief, that there's stuff sitting in the bathroom cabinet that when someone else has pain in the same family or even a friend, they are having access to opiates and then potentially becoming addicted. I think we see much less of that in Europe, because certainly in the UK, because the prescriptions are much more parsimonious, so we're giving out less drugs. Have
you checked your drug cabinet at home? This is a very personal question, but did you find any opioids in there?
We don't have any.
Good, well done you. Joff, I'm going to bring you in. Any in your cabinet? Maybe you shouldn't admit to that on it. Okay. Do you think possibly someone like you in the UK might find some opioids?
So much better phrased. I think it's very rare that people do. That's a difficult question, but I think there are going to be some patients, obviously, and people that have access to opiates, narcotics. But I think, having spoken to some American colleagues, the amount that patients go home with, and therefore, they're not going to use the enormous bag of narcotics that they're sent home with just for the 2 days post-operative pain they're going to have, and therefore they start accumulating large volumes in their house, and that's always going to be a risk.
Okay, so you have intermediate stroke major inpatient surgery in the places you've worked at in the UK. You haven't had any opiates for 24, 48 hours. You're going home. Will you go home with opiates, and how many would you go home with typically?
You wouldn't go home with opiates.
Okay, Mike?
You might, but it'd be 5 to 7 days as opposed to a month prescription.
Okay. Pat?
I really don't want to tell you what we do in the United States because it's so out of line. The narcotics in the cabinets at home of the average American who's had surgery are probably there.
Okay.
The diversion of those drugs is enormous in the country, and those people becoming addicted by stealing, diverting, doing something generous for a neighbor who has pain and giving them a pain medication is an epidemic in the United States. Convincing the American physician to change practice you have to go back and look at what happened in the 1990s when pain became the fifth vital sign for every physician in the country, when medical legal ramifications of not prescribing enough pain medicine for the physicians was building, and it's become, really up until this recognition of the narcotic epidemic, it was a huge burden for the physicians. Those things have to change, and they have to change from the very, very top of the government.
So part of the discussions we had as well was that there's been this sort of driver, this quality measure, which is all based on the pain score. So hearing stories whereby you're going to get pinged if your pain scores aren't recorded, you're going to get pinged if the patient's pain scores are high. So of people waking patients up to ask them if it hurts, and when they've been woken up, they say, well, it hurts now. What's the score? And it's at the scale where you're going to get pinged. So the answer is get some narcotics. Is that real?
That is more than real. That's the way it works in the United States for the most part. And we've seen it. I'll give you a little anecdote at our place. We started this enhanced recovery program probably about 5 years ago. Last year, I had a very astute nurse come to me and tell me a story. She had her child, she was a teenager, 15 years old, go in for an arthroscopic examination of her knee. She had a block, which was standard for us. The orthopedic surgeon sent her home with 30 OxyContin 10s. The mother said, she doesn't need any of those. She's not hurting right now. Why would she need those? So that education process at our place was unique and stopped that prescription, but that's not the case around the country.
That's scary, isn't it?
That is scary.
Yeah. I've heard people tell me stories of children under the age of 18 having dental extractions going home with 90 tabs.
Yes, and you know, the dentists of America are behind us a little bit on this. I mean, I don't know how far behind, but they don't want that phone call.
Okay. Well, we've, to a certain extent, we've all created that paradigm as well, haven't we? We've said, we've promised people it's not going to hurt. We've discussed this frequently. It is going to hurt.
Yeah.
That it is going to hurt. You know, come on, someone sticks a knife in you, it's going to hurt. Takes a tooth out, it's going to hurt. And that the objective of the pain relief should be to make it tolerable, to be able to allow you to drink, eat, and mobilize. It shouldn't be to be asleep and pain-free.
That's the conversation we're having with our patients now, is to tell them that nothing in life is free.
Yeah. Surgery
hurts. We will manage your pain. You can help manage your pain, but it's not going to all go away unless we make you obtunded.
So we'll leave that subject for a second because we're going to have a big session in the meeting about it. Pat, this is... Where do you think we are on the enhanced recovery adoption curve? We're going to be asking everyone this. Yesterday we were told that we thought we'd gone past the inflection point or possibly at the inflection point.
In the United States?
Yeah.
I think that there's a lot of conversation about it. When you talk about compliance with an overall program across the country, I think people are saying they're doing enhanced recovery and putting that label on their hospital and what they're doing.
Yep.
But as far as being compliant with a whole program of the perioperative management of patients, I think that's still in the infancy.
So this is the 6th, I think, meeting we have here. So that means we've been at a pretty long time now. Now, adoption of many things takes 20 years. Do you think this is going to take 20 years?
Not like the British Navy with scurvy. What was that, 163 years?
Mike, you know the history of that. James Lind, was it?
Yes. James Lind. Yeah, no, we weren't so quick off the mark there. And I think intriguingly with enhanced recovery, I think we had the national program which you led, Monty. We were pretty quick off the mark, but the striking thing is how we have drifted back a little bit.
Yeah. Talk about slow adoption. We're going to have in Journal Club. We're going to talk about balanced electrolytes versus saline. The New England Journal of Medicine papers recently. That debate started in 1880. Okay,
yeah,
can anyone trump that one?
The British Navy was.
All right.
Pat, thank you very much indeed for joining us. Have a great meeting. Thanks, buddy.
Thanks.
Take care.
Thank you.
Thanks, Pat.
Thanks.
TopMedTalk.